Hi, I'm Dr. Todd Levine, and I work at Phoenix Neurological Associates, and I'm also the director of Corinthian Reference Labs. And I wanted to take a few minutes just to talk to you about the value of epidermal nerve fiber density testing, and more importantly, what we should do with the results and how we evaluate our patients. So it's important to start by understanding what we mean when we say a patient has an isolated small fiber neuropathy. We're talking about patients that have normal neurologic exams, normal nerve conduction studies, but who have a predominance of sensory complaints that suggest that something is wrong with their small fibers. Because there's no objective evidence in our exams or our nerve conduction studies, we need some ancillary type of test to prove that there's damage to their small nerve fibers. The gold standard at this point is to do intraepidermal nerve fiber density testing through a small punch biopsy. But one could also look at QSART, one could do autonomic testing, and one could do sweat gland analysis. But the bottom line here is what we're referring to are patients that have a pure small fiber variant of the typical neuropathies that we see in other conditions. But like these other typical neuropathies, the phenotype is very important in understanding the underlying diagnosis. So the first thing to understand is that doing one site gives us some information, but not nearly as much information as if we do 3 sites. And the 3 sites that we recommend are the proximal thigh, the distal thigh, and the calf. And the pattern of abnormalities on these biopsies, as I'll show you, gives us a lot of information about the underlying etiology. So the first phenotype we call ISFN1, or isolated small fiber neuropathy 1, or a non-length dependent pathology. So when you get the 3 different sites on these patients, what you'll see is that the proximal sites, for example, the proximal thigh and distal thigh, are abnormal, but the distal site at the calf is normal, and that's what we call non-length dependent. There have been many papers in the last 5 to 10 years that have suggested that patients that have a non-length dependent pathology are more likely to have an immune-mediated diagnosis. So we might see this with Sjogren's syndrome. We might see this with specific autoantibodies, for example, against fibroblast growth factor receptor 3, or TSHDS, or other immune-mediated neuropathies, which may at some point even involve a spinal tap to look for the spinal fluid protein and the IgG synthesis rate. And what all of these would tell you is that these are potentially treatable diagnoses. The second we call ISFN2, which is a length-dependent neuropathy. And so these are patients where the distal sites, the calf or the distal thigh, might be abnormal, but the proximal sites are normal. These are the more typical forms of neuropathy that you might see with diabetes or impaired glucose tolerance, Sjogren's syndrome or sarcoid, or even underlying monoclonal gammopathies. The third form we call a multifocal form, and this was described many decades ago as a Wartenberg sensory neuritis, where individual patches of nerves are damaged. So you might see this, for example, where the proximal thigh is abnormal, the distal thigh is normal, but then the distal calf is abnormal as well, so it's very patchy. And you can see this again with diabetes, but you'd be very concerned, for example, about some form of a systemic vasculitis, sarcoid, or even HIV can present this way. The last form we call the autonomic form, and these are patients where their intraepidermal nerve fiber density is normal, but when you look at the sweat gland analysis, what you see is a decrease in the number of autonomic nerves in those sweat glands. And so these patients tend to have very autonomic predominant complaints. The reason this is an important form to recognize is that it can present acutely, almost like a Guillain-Barré syndrome, where it would need to be treated. But we now know there are more chronic forms, such as acquired amyloidosis or inherited amyloidosis, that may also be treatable and present as a predominant autonomic neuropathy. So what we see is that by doing 3 different sites and analyzing the specific pathology in these patients, we get a much better idea of what their clinical phenotype is, and therefore a better idea as to what the underlying diagnosis might be. By looking at this, we're not only trying to put our patients into smaller buckets, but we're really trying to get a better and more educated analysis of the types of tests that we need to do on these patients so that hopefully we can find more and more treatable etiologies for small fiber neuropathy. Thanks for your time, and I hope you found this to be helpful.